Well, good afternoon, and once again, thank you all for joining us today for the 2020-2022 State Health Improvement Plan Health Behaviors Work Team meeting. This is Regina Clay, Health Policy Analyst at the Health Policy Institute of Ohio. A few things that we want to keep in mind before we start the meeting today. For now, everyone is in listen-only mode. We definitely want this to be a robust and interactive meeting. So if you have questions or comments, please type them into the question box here. If you would like to raise your hand and comment during today's discussion, we will unmute you. If you have muted yourself, you will have to unmute yourself in order for everyone else to hear your comments. Once again, make sure that you've entered your audio PIN. You'll need to log into the webinar first before calling in order to get access to your PIN. As a reminder, the meeting slides and recorded webinar of today's meeting are available on HPIO's Shaw Ship webpage. Here's the stakeholders that are involved in the SHIP, and to locate yourself, health behaviors is at the foundation of the structure outlined in red. So now I'd like to introduce my colleagues at HPIO. Joining me in the room today, we have Amy Bush-Stevens, Haley Aka, and Alana Clark-Kirk. So in a moment, Amy will provide some more background information on the SHIP process and purpose and list of outcomes and indicators for health behaviors. Then we will move into some discussion on setting overall targets, identifying priority populations, and setting priority population targets. We definitely don't want to hear ourselves only on the webinar, so we encourage you guys to speak during today's meeting. We will conclude the webinar today with next steps for the project. And I'm sure you guys are very familiar with the objective, and it is for HPIO and ODH to have the guidance needed to finalize the overall targets, priority populations, and priority population targets for health behaviors. As a reminder, no final decisions will be made on the call today, but your input will guide the final decisions that are made over the next few weeks. And now I'll hand it over to Amy to share more about the review of the SHIP process and purpose.
Thank you, Regina. Good afternoon, everyone. This is Amy Stevens at HPIO, and it looks like we have about 20 folks on the call today so far, so that's great. And it looks like many of you are repeat customers. So some of you have participated in these target setting calls that we've had over the past few weeks. And the spiel that I give at the beginning of these webinars is about the same. And then we will dive into the details of health behaviors toward the second half of our call today. So thank you very much to everyone who has joined us. I'm going to start with a little bit of background on the State Health Assessment, State Health Improvement Plan process. This is the timeline for the SHIP. We will be developing the final SHIP to deliver to the Department of Health by the end of September. And so you can see where we are here in July in this target setting and priority population phase of the work. And then as we transition, actually starting next week, we will start focusing on strategy selection. Throughout this process, there's also a parallel maternal and child health assessment that's happening that we're coordinating with, and I know some of you are involved in that work as well. That is a maternal and child health and maternal, infant, and early childhood home visiting MICV assessment. The purpose of the SHIP is to get us all rowing in the same direction to improve population health in Ohio. That's why it's important to be concise and prioritize toward common big picture goals. We know that prioritizing is difficult work, but it is necessary if we're going to be strategic about working together to improve the outcomes that we all care about. The SHIP will be a tool to align state agencies, and we have a steering committee for this work that is made up of directors or their designees from all of these agencies. The SHIP is also a tool for local level partners and is designed to improve alignment and collaboration between all the different kinds of partners shown here on the slide and others as well. The SHIP is our opportunity to track our progress over time. This chart takes an early look at Ohio's progress on the objectives in the previous SHIP. And on this chart, green indicates things are improving, yellow means little or no detectable change, and red means things have gotten worse. We know we have a lot of work to do. The goal is to get Ohio into the green. So this is kind of the vision for where we would like to head. The SHIP is really all about progress and improvement. And the goal of the SHIP is to ensure that all Ohioans have the opportunity to achieve their full health potential. And that means eliminating disparities and inequities and achieving equity. Now we'll take a look at the framework for the SHIP. This really guides all of our work. And thank you to everyone who has contributed over the past few months to fleshing out everything that's listed here in this framework. This is a somewhat different framework from the one that we used in the previous SHIP. We made some revisions. We called it Flipping the SHIP, where we put that focus on those community conditions and the other health factors in blue on the left. We simplified some of the language so that it will make sense to sectors beyond health, so those questions across the top. And then we've also elevated equity in the framework. And that red box there is where health behaviors fits into the overall picture. So in the second half of this webinar today, we're really going to be zeroed in on those health behavior outcomes, but it's important to keep in mind how all of these different factors and outcomes are connected. Obviously, there are lots of relationships between all of these different factors. These are the main components of the SHIP. So we have the SMART objectives. Those are specific and measurable objectives. We have priority populations. Those are groups with worse health outcomes. And then we have evidence-informed strategies and strategies to reduce disparities, inequities, racism, and discrimination. Today, we're focusing here on the SMART objectives and priority populations. And then as we move into August, we'll be focusing on the strategy side. As a reminder, this is the objective for our meeting today. Now, we'll do a recap of the previous health behaviors webinar that we had on June 20th to see where we've landed with the set of outcomes and indicators for health behaviors. So to remind you of the prioritization process that we have used throughout this journey. We started this work back in October of 2018 with regional forums where we gathered local stakeholder input. And then we also looked at the secondary data in the state health assessment. And I should mention that ODH will be releasing the state health assessment soon. So stay tuned for that. Watch your email inboxes for when that is released. We then shared the information gathered from those sources with the steering committee and the advisory committee, including the June 4th advisory committee, where we had a small group discussion that was focused on health behaviors. Then we had a prioritization survey in early June. and then the webinar on June 20th for the health behaviors work team. So all of the feedback gathered through this process has helped us to prioritize a concise set of desired outcomes and specific indicators for health behaviors. And before we get any further, we want to get a sense of how many of you have been able to participate in this work team throughout the process. So we have a poll question for you. Did you participate in the June 20th Health Behaviors Work Team meeting? That was a webinar. So let us know if you were able to call in for that webinar. No, but you were able to watch the recording or review the slides, or no, you just didn't participate in that at all. Okay, give you a minute to fill that out. What we're talking about today really builds on this whole series of work. And so if you're just getting involved in the process now, we welcome you. We welcome new folks to join the process as we go along, but we encourage you to check out the HPIO ShopShip website so you can see all of the materials from the previous meetings. And I think Alana's got the results for us. Okay, wonderful. So half of you participated in that previous webinar. Another good chunk of you were able to view the recording, so that's great. Okay, let's take a look at those outcomes and indicators. So this is what we were looking at on the June 20th webinar. Really focused on the big three here: tobacco, nutrition, and physical activity. And this shows the detail for the indicators that we prioritized as a group. And to get us to those specific indicators, we had, yes, all right, I'm gonna move us on to taking a look at target setting, the target setting process overall. So this is part of developing our SMART objectives. And I'm sure many folks on the call are familiar with SMART objectives. Here are some examples of SMART objectives from the previous SHIP. And today we're focused where those red arrows are on the targets, setting targets, and identifying priority populations, that orange row. And this is an example of what it looks like when we report out on progress toward the targets. The purpose of setting targets for health behaviors is so that we can monitor and report on those indicators over time. So it looks like that. So what we're doing here on this call today is to help us get to a place where we can have these types of SMART objectives in the SHIP for health behaviors so we can report out on it like that. Looking at the components of a SMART objective, specific and measurable refers to the indicator and the data source. So we have already decided upon those components, and that's that list that I shared a minute ago. Achievable and realistic refers to the target data value, and that's what we're going to be talking about more today. Time-bound refers to specific years for baseline and target data. And we've set 2022 as the target year for all objectives in the SHIP, and the baselines vary depending on the data source. It's worth spending a bit more time talking about these two words here, achievable and realistic. We think it's also important to be aspirational when we're setting these targets. And so there's really a tension between being achievable and realistic versus being aspirational. As we set our targets, it could look like this, where we focus more on being aspirational, so really reaching for the stars when we set those targets. Or like this, we could focus more on an incremental approach that would be seen as more realistic. Or we can strike a balance where we would look at what seems achievable given current trends, but then really reach a bit and kind of push ourselves to reach for a better outcome than we would see with the status quo. And now we would love to hear your thoughts on this balance and other considerations for setting targets. So we have our first discussion question for you here. When setting SHIP targets, do you think the emphasis should be on being achievable and realistic, aspirational, or a balance between the two, and why? And so this is your opportunity to raise your hand. You should see the little hand raising icon to the top right of your screen. If you would like to contribute to the conversation, please raise your hand and we will unmute you. Again, make sure you've entered the audio pin, and if you've also muted yourself, make sure you unmute yourself. You can also use the question box to type in comments if you'd like, but we do kind of prefer it for folks to raise their hands because we'd love to hear some other voices besides our own voices on the call today. So what are your thoughts on achievable and realistic versus aspirational, or striking a balance? Okay, I'm taking a look at the question box here and don't see any questions or comments typed in yet. And don't think we see any hands raised. On the previous 4 webinars that we've had where we've asked for feedback on this, I think overall we've heard interest in striking a balance. Certainly some folks talking about the importance of being realistic, others talking about the importance of being aspirational, and so I would say the general mood of the group has been to try to strike a balance. Okay, it looks like we have a comment here from Cheryl, the balance. Okay, and we have a hand raised from Kathy. Kathy, go ahead.
Kathy Cowan in Columbus, Ohio. I would agree too with the balance. The aspirational certainly helps people to strive and put a little more effort in, and it also speaks, we've found that it speaks to, in particular, community leaders and policymakers, because they really want to see something that's motivating to people, you know, like that's something that's kind of audacious and go for it. And also, if everything is achievable, then you end up all green, and then that raises other kinds of questions to people.
All right, thank you for that. And I see a comment here from Hope. I liked what one woman said in another meeting, that it's important for realism at the local level, but the state level can be a little more aspirational. So that is certainly an important thing to point out, that the SHIP sets out the overall big picture goals for the state, and then is used by local communities, local health departments, hospitals, and other coalitions to then set their own targets based on, you know, what the baseline is, what the reality is on the ground in your local communities. And of course, sometimes that'll need to look quite different from the state targets overall. So that's definitely important to keep in mind, that there are targets set at the state level in the SHIP document, but then also at the local level. But those local level targets, of course, won't be in the SHIP. That'll happen independently in each local community. Okay, no other hands. I'm going to move us along to a related question, which is, what experiences have you had with setting targets in your own organization or community? Have you had any experiences with setting targets that were too ambitious or not ambitious enough? And what are some lessons learned to inform the SHIP? So if you have done this work with setting targets and tracking progress over time, we would love to hear about it, either at the local level or at the state level. Be a great time to raise your hand. Okay, we have Cheryl has a hand raised. Go ahead, Cheryl.
At the local level, when we have set targets that were not very ambitious, then we achieved them relatively quickly in the what used to be 5-year process, now turning into a 3-year process. But once they were achieved, they were kind of forgettable and off the radar for people. So I think there is definitely a balance in having something that can't necessarily be achieved in a 1 year or even necessarily in the 3-year time frame to again aspire to something greater, to challenge ourselves, to dig deeper and to stick with it and press forward.
Okay, yeah, thanks for bringing up that 3-year time cycle piece as well. So as folks are probably aware, the State Health Improvement Plan is on a 3-year planning cycle. And starting in 2020, all of the local health departments and hospitals that are required to do assessments and plans will be on the same 3-year cycle. 3 years is obviously not a lot of time to achieve some of these big picture, long-term outcomes. And so we did have some suggestions on a few other calls to also think about maybe some longer term time horizons as well. And so that's certainly something we can think about. Okay, I'm gonna move us along here to talk about priority populations. So these are groups of Ohioans who have experienced worse health outcomes or worse outcomes than the overall population. And these are examples of the priority populations that were included in the last SHIP. So we were looking at race, ethnicity, age, gender, income, education, disability status, and geography. And that varied so much depending on the source. So some sources allow us to look at a lot of data disaggregated and others don't allow for any. And so we're looking again at these categories this time around. And then also we do have some new data from the BRFA survey that we can use that looks at LGBTQ status. And so that's another factor that we can consider. Okay, and in a minute, Haley is going to say more about what data we have available for health behaviors, so we can think about tobacco, physical activity, and nutrition specifically in what we want to identify as priority populations. And then we'll talk about setting targets for priority populations. And there are a few different ways that we can think about doing that. And to illustrate 2 ways of setting priority population targets, I'm going to use this apple tree metaphor that I'm sure many of you have seen before, or similar graphics that talk about equality versus equity. And in these pictures, apples represent optimal health outcomes, the ground represents the social, economic, and physical environment, and the crates represent policies, programs, and other resources. In this first image, all 3 people have the same policies and programs, but 2 of them can't reach the optimal outcomes because of where they're starting from. So those apples are at the same place, but the crates are all the same size, so we don't have full equity. In the second one, the apple crates are tailored and targeted so that everyone achieves optimal health outcomes. And this is what health equity looks like. Now we're going to use this picture to talk about 2 ways to set targets for priority populations. In this first approach, we're calling universal targets, we would set the same target for everyone. So the apple would be at the same level. So for example, we would have the same target for the Black infant mortality rate as we have for the overall Ohio infant mortality rate. This approach makes the case that we must eliminate disparities and inequities, and it's consistent with the goal of achieving equity. But of course, to be effective, it needs to drive targeted allocation of resources and funding and power. In other words, the targets are universal, those apples, but the strategies, the apple crates, need to be targeted and tailored with more resources directed toward groups who have the furthest to go to reach the apple. So the two most important things to note about the universal targets approach here is that the apples are the same and the crates are different. The crates are tailored. The second approach would be to vary the targets for each population. So priority population targets would be based on trends and baseline data and may therefore be different from the overall population targets. This approach is not consistent with the goal of achieving equity, but it is seen as being more realistic. So this kind of brings us back to the tension between being achievable and realistic versus being aspirational. Now we want to open it up again for questions to get your feedback on this and which approach you think we should use in setting priority population targets in the SHIP. So should it be the universal or the population varied approach? And I'll flip back to those just to remind us of what those are. Again, please raise your hand if you'd like to let us know what you think on this. So this is the universal target approach where the targets would be the same. So those apples are the same. And then the resources would need to be different, would need to be tailored in order to get us to those targets. And then this is the population varied approach where the apples are different, reflecting different targets, for example, for Black infant mortality versus overall Ohio infant mortality. So let us know which approach you prefer. Again, we encourage you to raise your hand or you can use the question box. And we've got a comment typed in here from Mandy. For health equity, I believe we need to be aspirational and use the universal approach. So the universal targets. Okay, thank you, Mandy. And we have Carrie has her hand raised. Go ahead, Carrie.
I think that there's a way to strike a balance between the two, especially when you think that having tailored approaches is really can be unrealistic when we have limited funds, and we all know that public health funds are generally limited. But setting goals that may be different for each group, but still reduce the gap between the two populations that are seeing different outcomes, so that we may still have a difference between Black infant mortality and white infant mortality, but if the gap is closing in 3 years, it's heading the right direction, if that makes sense.
Yeah, so really looking at that disparity and reducing the disparity gap. We've got a few typed in comments here. Karina says population varied targets is the preferred approach. Andrea says, I agree with universal targets. It may send the wrong message to have different targets for each group. Okay. Karina, do you want to say anything about why you recommend the population varied targets? And I don't think we have any hands raised. Okay, well, I'm about to transition us. Oh, we have a comment here from Cheryl. Agreed, if the population targets are varied, it hides the inequity. Universal puts a spotlight on it. Okay, and Karina, I think it helps to set apart those most in need. So that's in talking about the population varied targets. Okay. All right, I'm gonna pass the baton over to Haley in a minute here. Any other thoughts on this question of the best way to set priority population targets? We know it's pretty challenging. Okay, take it away, Haley.
Thanks, Amy. And thank you to all of you for being on the call today. We really appreciate your insights. Just flipping through all of these slides. Our objective in the next part of this meeting is to gather some additional guidance from you all in order to really finalize those overall targets, priority populations, and priority population targets for our health behavior indicators. Again, we're not making final decisions on the call today. What we're doing is gathering information from all of you that will help inform those decisions in the coming weeks. As a reminder, the desired outcomes in the health behaviors priority area are these three in the blue boxes on the left. They're to decrease tobacco and nicotine use, to improve nutrition, and to increase physical activity. And these indicators were selected based on your all's feedback at our June 20th meeting, the results of the prioritization survey, and in consultation with other subject matter experts. So here's how we'll move forward on the call today. I'm going to review really briefly the data within each of these indicators for the ones that we have data for today. That's going to be really brief, and then we're going to move into some conversation around the factors that we should be considering when we're setting targets for each indicator and when we're choosing those priority populations. So let's move into our first area, tobacco and nicotine use. So within this desired outcome, we have two indicators, adult smoking and youth all tobacco use. Adult smoking is the percent of adults that are current smokers from the Behavioral Risk Factor Surveillance System, which I'm going to call the BRFIS on the call today. In the online SHA, we see that this adult smoking rate in Ohio is higher than the US rate overall, and that we well exceed the Healthy People 2020 target, which was 12%. And you see we're at 21% in 2017. The other indicator here is youth all tobacco or nicotine use. And this comes from the Youth Tobacco Survey, which this year is being wrapped into the YRBS, the Youth Risk Behavior Survey. This indicator will include many different tobacco products, so the percent of middle and high school students who use cigarettes, smokeless tobacco, cigars, a variety of other things, but I want to make sure you see that this includes e-cigarettes and other vaping products. So that's included in this metric here. The YRBS, which includes, again, the Youth Tobacco Survey, that data will not be available until later this year, so you'll see that that data is pending at this time. And because 2019 will be our baseline year, we don't see trend for that at this point either. So we're going to have to revisit this data when that's available later this year. But I think we can go ahead and talk about some of the factors to consider when setting targets for these things anyway. So here's our discussion question. So excellent time to raise your hand as we think about this. What factors do you think are important to consider when setting targets for these indicators? So are there measurement issues related to these indicators that will impact the targets that we set for 2022? Are there federal, state, and local policy changes that might impact what might happen in the next 3 years? Other trends and issues related either to adult smoking or to youth tobacco use? What should we keep in mind as we're setting our 2022 targets for these? So go ahead, raise your hand. You can also type into the question box. Kathy, we see your hand raised. You can go ahead.
I would say that probably the biggest one would be the change in the tobacco 21.
Yeah. Yes.
Right, and that's
Excellent.
statewide now?
Yes, it is. Was part of the budget, correct? Yes. Yes. Good point.
So that would influence both of these indicators,
Yeah, it would.
potentially.
Yeah. Yes, good thing to keep in mind. Other things happening in the policymaking environment or with these metrics that we need to make sure we consider. Is there anything happening with e-cigarettes specifically that we need to make sure we know? Mandy has a comment here. Right, that the implementation of Tobacco 21 will be a factor for the youth all tobacco use. Absolutely. And then another from Mandy. A lot of activity around youth e-cigarettes that we hope will have an impact on youth use of e-cigs. Yeah, lots of things happening in communities around the state. Thank you for that. Another. And Mandy says there are several work groups that are planning to implement initiatives. So lots of activity happening around that e-cigarette use. So maybe as we think about that, we can be a little bit more aspirational related to youth all tobacco use. Do people agree with that? Because there's lots of activity happening. We have this new Tobacco 21 policy. Maybe we can be a little bit more aspirational with this target. Cheryl has her hand raised. Go ahead. Cheryl, we've got you unmuted.
I'm sorry.
Oh, that's okay.
The FDA had recently launched like a $60 million campaign against teen e-cigarette use, and it could be an indicator that some federal funds could come down to the state level to help fund campaigns at the state level.
Okay, great. Great, that's helpful context. All right, a couple of additional comments from Andrea. It may be hard to tease out the difference between cigarette and e-cig use. E-cig use is going down, or e-cig use is increasing while cigarette use is going down. Yes, absolutely, and that's part of the rationale that the group had in selecting this all tobacco use metric, so that, because what we really care about is all of that kind of combined. And Andrea, and she's speaking for the adolescent population. So yeah, that is an important thing to keep in mind, that those things might cancel each other out a little bit, and that might make us think a little bit more closely about how to set that target. Okay, that's helpful feedback. Let's move into talking about the priority populations for these, and then if additional thoughts come out about the target setting, we can absolutely cover that as well. So here we see the adult smoking data. It comes again from the BRFIS, and the BRFIS can be broken out in a variety of ways. So here, aside from pregnant women, which is that first potential priority population, the rest of these are populations that have a smoking rate that's at least 10% higher or 10% worse than the overall adult rate. Pregnant women are also on this list because, as we learned from the online SHAW, Ohio's rate of smoking during pregnancy is twice that of the US rate. And so the group in previous stages suggested adding this as a priority population to that adult smoking indicator in the SHIP. Of these priority populations, potential priority populations on this list, the highest rates of adult smoking are among Ohioans with low educational attainment and with low incomes. And then again, because our youth tobacco use metric comes from the YRBS and that data is pending, we're going to have to revisit what breakouts are available and what priority populations we can look at for youth all tobacco use once that data is available. But thinking about the adult smoking priority populations, what factors should we be considering for identifying priority populations for this indicator? Are there certain priority populations that you feel strongly should be included in the SHIP, and why? So go ahead, raise your hand, and we can talk about which of these should be elevated. And one thing I want to make sure that I say, for two of our indicators today, we have these sort of long lists of potential priority populations. And certainly each of these populations is important and is worthy of being considered when thinking about our smoking rate or whatever indicator we're looking at. But in the SHIP, because we have so many indicators, we want to make sure that we're being a little bit specific about who our priority populations are so that we can see some measurable change in that time period. So that's why we're being choosy. Okay. I see from David a comment that adults with disabilities are more than twice as likely to be current smokers. Don't believe that we have a large enough sample size for youth with disabilities, but studies in other states indicate that rates may be higher among students with disabilities. So some thoughts around elevating people with a disability as a priority population in the SHIP. That's helpful. Thanks, David. Other thoughts about priority populations? We have a hand up. Bobby, you can go ahead.
Hi, so I think we really ought to look at that, women who are pregnant. While it may not rise to the level of other Ohioans, we do know that it's a contributor to premature birth, infant mortality, and those are certainly other things that we are needing to combat in the state. So I think that we should look at that. And then I also just think about what we can realistically impact, and that has to be a critical point in life for a woman to be motivated to stop smoking if we can provide the appropriate interventions. And so I think we should look at that.
Yeah, great. Thanks, Bobby. And I think that brings up a really important thing when we think about the SHIP overall. So the health behaviors area with these indicators included are part of the health factors that we know influence our health outcomes. So one of the factors that we're thinking about when elevating these things is its connection to other priority outcomes in the SHIP, which might include things like low birth weight and infant mortality. So I think that's an excellent reason to think about elevating women who are pregnant as a priority population within adult smoking. So that's really helpful. All right, we see a couple of questions or comments in the question box. Carrie says that we should keep in mind the possibilities of interventions and how they can be targeted to the priority populations we choose, which is an excellent point. And in the coming weeks, we're going to be having some meetings related to strategy selection and thinking about what interventions we'll be using to target these things in the years to come. And so an excellent thing to keep in mind as we're selecting. And then Mandy says, low-income population will usually have large crossovers with other disparate populations, which is a comment that we've heard before in other groups when we're talking about priority populations, that maybe selecting low income gets at some of these other populations in some different ways. So that might be a good reason to select that. And then Cheryl says she would elevate low income and low educational attainment, and that she wonders if the pregnant smoker data could be disaggregated by education and income, which is a great question that I don't know the answer to, but it's something that is interesting to look into. So thanks, Cheryl. We appreciate that. Okay, and then Amy says that she remembers persons with a behavioral health condition are in the mental health and addiction area in the SHIP, right? And I know these rates are maybe even higher than people with a disability. Remember that persons with a behavioral health condition. Oh, for folks that have a behavioral health condition, that their smoking rates are higher. And we're thinking that maybe that information is in the NUSDA. Amy is writing me a note, so that's something that we can look into, because that is something that we hear, that rates among people with behavioral health conditions, smoking rates are higher. Okay. All right, we're going to move forward. That was really, really helpful feedback. Thank you all. And if throughout the call, if you have additional feedback or additional thoughts about any of these, feel free to just drop things in the question box. Even if we don't get a chance to read all of those aloud, those comments will come with us after this call, and we'll be sure to address and look through all of those. Oh, poll question. Let's go ahead and throw the poll. We're going to ask for your direct feedback about which of these priority populations you think is most important to include in the SHIP. So you only get to pick one, your very most favorite priority population that you think should be addressed for adult smoking in the SHIP. We'd really love for everyone to participate in this poll. So we're going to give you a few more minutes here. Okay, last chance to vote. And Alana is going to give us our results. Okay, so we see a lot of love for low income and women who are pregnant, and some for people with a disability as well. So that is helpful feedback that we'll take with us. And just remember, just a reminder that this is all feedback that we're gathering today, and that final decisions aren't being made right now and will be made in the coming weeks. We'll be able to look at all of your feedback and consider it closely. All right, our next priority in this area is improved nutrition. We have two indicators within nutrition. That's youth fruit consumption and youth vegetable consumption. Both of these indicators also come from that YRBS source. So 2019 data will be our baseline and is pending at this time. So we don't currently have data for these indicators or for priority populations. So we won't be able to have a conversation about this on the call today, but we wanted to make sure that you saw what those indicators are going to be. And if you have any feedback related to priority populations that you think are especially important when you're thinking about youth nutrition, youth fruit and vegetable consumption, or any factors in the environment that when this data comes out, you want to make sure that we know about, now's a good time to drop those things in the question box and we'll make sure to take those with us. And then our final area is increased physical activity. So this includes, again, two different indicators, child physical activity and adult physical activity. The child measure is percent of children who are active at least 60 minutes per day. So it's a child physical activity measure, where the adult measure is percent of adults who report no leisure time physical activity. So this is from the BRFIS, an adult physical inactivity measure. Both of these metrics are in the online SHA, so we have some comparison to the US and some trend for both of these. For that adult physical inactivity metric, the Ohio rate is higher than the US rate and is trending in the wrong direction. So we see more inactivity as the years go on. For the child physical activity metric, the Ohio rate is actually better than the US rate. So Ohio children are more physically active than US children overall, but the trend from 2016 to 2017 did go in the wrong direction, less activity. So some quick background on those metrics. Same question as before. We'd love to get your feedback on what factors you think are important for considering as we're setting targets for these indicators. So measurement issues, the child measure comes from the National Survey of Children's Health, and the adult measure comes from the BRFIS as compiled by America's Health Rankings. So any measurement issues related to these, anything's happening in the policymaking environment at the state or local or federal level that would impact setting targets for these for 2022. Bobby asked about nutrition. Are we only considering middle school and high school nutrition? Recognizing that data points may be difficult to identify for other ages, perhaps we should also consider access issues and looking at number of produce perks benefits to consider some other access to healthy food indicators. So the reason for looking at only, I'll flip back to nutrition, for middle school and high school is that that's the data source that we're working with. The YRBS is a survey in middle schools and high schools. So that is what that data will be looking at. But we can absolutely look at produce perks as a strategy related to nutrition and increasing fruit and vegetable consumption among youth. And we can look at the number of produce perks used as a process indicator to see how we're moving on this metric. So that's really important and a good thing to bring up. But yeah, that data will be for those age groups. And then Diane says, related to nutrition,
While these are ideal nutrition outcomes, we seem to be missing out on food insecurity. And key strategies for improving food insecurity will ensure access to food and nutrition programs such as WIC and SNAP. So great to be drawing our attention to a few more strategies that get at these things. And we did, when we were, Abs, Amy, do you want to speak to this? Because some of these at previous meetings are other indicators that were considered. So I'll let Amy.
Sure. So food insecurity was one of the outcomes that we considered in the community conditions bucket, and it wasn't prioritized by the group. Instead, the focus is on poverty, housing, education, and adverse childhood experiences. But I think that as we look at strategies, there may be some things that come up either for improving nutrition or related to poverty, actually, that might connect with food insecurity. And so we'll make a note of that and see what the ways are to kind of connect that, because obviously it's very related.
Thanks, Amy. So feel free, if you have additional things related to nutrition, you can drop them in the box. I do want to get us back to physical activity because we are rapidly running out of time. So let's move forward. If you have thoughts about things happening in the environment or measurement issues related to target setting for these indicators, feel free to drop us a note in the question box. I want to move us finally to our priority populations for physical activity. And just to note that for our child physical activity metric, that National Survey of Children's Health metric cannot be broken out into subgroups, so there won't be priority populations for child physical activity. For adult physical activity, again, this comes from the BRFIS, so it's able to be broken out in all these ways. And again, these are the groups that do at least 10% worse than adults overall. And so if there's any feedback from you all about which of these priority populations are most important to elevate, we can take a couple of minutes of conversation around these. And again, you'll see those with the highest rates of physical inactivity are adult Ohioans with low educational attainment and low income. So any thoughts for adult physical activity, which of these priority populations are most important to elevate? We'll also be throwing a poll about this. Yeah, Amy has a question.
So on several of these, you might have noticed that we have both low educational attainment and low income. So those are two categories that we can get disaggregated data from the BRFIS. And so in many cases, what we see is that both low income and low educational attainment have higher rates than Ohio overall, or sometimes the highest. And I'd just love to hear from the group if you have thoughts on whether we should emphasize education or income as a priority population, because obviously there's a lot of overlap between those two. And so would love to hear guidance on the wisdom of selecting one or the other. Thanks.
So any thoughts related to what Amy just asked about income and education, or other thoughts about which to elevate? David Ellsworth dropped some information in the question box related to people with disabilities and their challenges related to physical activity and obesity, which is great for us to keep in mind. Any other thoughts? All right, we're going to go ahead and throw this poll question, and we'll get that level of feedback from you all. So which priority population should be selected for adult physical activity? Again, this is your very most favorite, the one you want to make sure is definitely in there. For this one, there are 6 options and only 5 slots in the poll, so we combined low income and low educational attainment. So we won't get at Amy's question here, but if you want to go ahead and let us know in the comment box, in that question box, which of those two you think is most important, that would be another way to get at that. We're seeing some folks doing that already, which is really helpful. Another couple of seconds to make sure that everyone is able to vote. And I'm seeing a lot of love for low income and low educational attainment, which Alana is going to show us the results of that, which is fantastic. So those of you that voted for low income and low educational attainment, if you would just quick in the question box, type income or education to vote for which one of those you think is most important, we'll take that back with us as well. Okay. So thank you, everyone, for your feedback and your participation there. I'll close this loop for you. A lot of people are saying income. We're getting a couple of education, people who want to focus on education, but I would say 2/3 are saying income. So that's helpful feedback. Thank you all. All right, I'm going to pass it over to Erigina, who's going to close us out for today.
All right, thank you, Haley. So moving forward, HPIO will send you a link to the final SMART objectives list with targets by August. So keep a lookout in your inbox for that. The next strategy selection meeting is in person at HPIO next Tuesday, so right around the corner, July 31st. Your in-person attendance is required. We want to see your faces, as there won't be a call-in option for this meeting. And what would an HPIO meeting be without small group discussion? So we want you guys to be there for that. The agenda for the strategy selection meetings will be posted on HPIO Shawship webpage, including directions to HPIO and parking information. And before we get out of here, I would like to leave you all with the quote from Andrew Carnegie that I believe embodies the essence of these work team meetings and our collective efforts to improve the health of our state. And the quote says, "Teamwork is the ability to work together toward a common vision, the ability to direct individual accomplishments towards organizational objectives. It is the fuel that allows common people to attain uncommon results." This concludes our webinar for today. Let's get Ohio in the green. You guys have a great day.